Dear colleagues, dear Chairman, good afternoon. I would like to thank the organizing committee for their kind invitation, and my presentation will be about geriatric assessment in decision-making for patients with advanced prostate cancer. As Dr. Papadopoulos said, it is quite important to evaluate the life expectancy and the health status in the clinical decision-making for screening, diagnosis, and treatment of advanced prostate cancer. Geriatric refers to medical care for older adults, an age group that is not easy to define precisely. Usually we define as elder population people who are aged 65 and over, but the International Society of Geriatric Oncology has set a threshold of 70 years old. As was said before, 60% of prostate cancer patients are aged 65 years old and older, and this is going to increase by 2040. The total number of patients aged 70 years old and older with prostate cancer will increase the next years, and we expect an increase in prostate-specific mortality, while the overall mortality is anticipated to be stable. There is great interest in setting guidelines for this group of patients, especially from the International Society of Geriatric Oncology. Their first effort was 15 years ago, and the most important conclusion was that treatment should not be based on chronological age, but on health status as established by screening using different tools. Usually the clinicians use the ECO performance status, but this screening tool is based mostly on mobility, and this has some major problems. And they suggest a more comprehensive geriatric assessment in older patients. A comprehensive geriatric assessment is not something easy. It's a multidisciplinary diagnostic and treatment approach that tries to identify medical, psychological, and functional limitations of frail older patients in order to coordinate a plan, a therapeutic plan, to maximize overall health with aging. It includes testing of several parameters, but to be honest, it is very difficult to perform such tests in everyday clinical practice due to lack of time or trained staff, and to be honest, not all patients above 70 years old need a comprehensive geriatric assessment. So, in clinical practice, we use this simple three-step model. At first, geriatric screening of all patients to identify those who need further assessment. The next step is a geriatric assessment in those patients with an abnormal result of screening, and geriatric intervention is based on the results of a comprehensive geriatric assessment in selected cases. As Dr. Papadopoulos said in his presentation, the basic tool is the G8 scale. It takes into account 8 parameters, and if the score is less than 40 out of 70, the patient is considered eligible for a geriatric assessment and possible geriatric intervention. And it categorizes patients into 3 groups: the group 1, which is fit patients; the group 2, which is vulnerable patients, but with a proper intervention, they will move to group 1; and the third group is the frail patients. Another tool is the Mini-COG algorithm, which focuses to dementia. It uses a 3-item recall test and the intuitive clock drawing test. It's free to perform in our office. And of course, there are several other validated tools, such as the clinical frailty scale. It runs from 1 to 9, with higher score indicating increasing frailty. The importance of this scale is that it correlates with 30-day mortality after surgery, and it is likely to predict the possibility of the patient to be discharged home after the operation. We should not forget that the whole part includes the geriatric interventions. Or to be honest, in clinical practice, only 50% of the proposed interventions are actually implemented, and the whole procedure needs a team which includes medical specialists, nurses, psychologists, social workers, etc. So at the end of the day, we base our decision based on risk stratification, mostly based on the G8 scale. Fit patients and vulnerable patients it's possible to be treated as younger patients, and frail patients are not valid for definite treatment, and symptomatic management is proposed in this group. Of course, the whole procedure is a shared decision making, and it's quite important to understand that in older patients, we may also wish to involve their family members, because this is particularly important when cognitive status is not the best. Since the presentation focuses on advanced prostate cancer, nowadays we have trials with age-stratified efficacy outcome impact and data regarding survival per age group. In hormone-naive metastatic status, all treatments are valid for younger patients, are valid for older patients as well, with the recommendation of primary prophylaxis with growth factors in case of docetaxel use. We should be really careful with the bone mineral density, and we should evaluate the status of the bones in all patients under the prevention therapy. And we should recommend the use of denosumab at 60 milligrams every 6 months to prevent osteoporosis and side effects of ADT. In metastatic castration-resistant prostate cancer, it's the same status. All treatments are also valid, but we must carefully evaluate the drug interactions and proactive management of adverse events in older patients. And it's quite important to perform an initial cardiac evaluation to treat the pre-existing high blood pressure and electrolyte disorders. And we must not forget that early palliation should be implemented, and that includes radiotherapy, bone-targeted therapies, palliative surgery, and pain treatment. Of course, more studies are needed, which will focus in elderly men with prostate cancer, and will define and validate ideal risk stratification methods, as well as management approaches that may be distinct from those from younger populations. All these are well documented in the EU guidelines, which they strongly recommend to use the individual life expectancy, health status, and comorbidity in our prostate cancer management. It is recommended to use the geriatric G8 scale, the clinical frailty scale, or the mini-POC tools to evaluate the health status. Depending on the results of the G8 score, geriatric evaluation may be needed in those who fail in the test, and to offer symptom-directed therapy alone in frail patients. Thank you very much for your attention.